Good morning, students. As a continuation of the earlier chapter, that is the terminologies what we discussed in the central nervous system infections. Today, we are going to start the new topic in that central nervous system infection, that is bacterial meningitis. In the earlier class, I mentioned that meningitis is the inflammation of the meningeal layers, that is mainly the pia matter and arachnoid matter. So the layers as well as the fluid present in between them, that cerebrospinal fluid, also will get infected in many of the bacterial infections. In today's chapter, we will discuss or study about them in detail. So coming to the objective of the chapter, at the end of the session, the students will be able to understand what are the different agents of bacterial meningitis, how the pathogenesis of the meningitis will occur, different clinical manifestations of the meningitis, how we can diagnose the meningitis in the laboratory, what are the different treatment modalities available to treat acute as well as chronic bacterial meningitis and its differences. And we will also study about the agents of pyogenic meningitis in this particular chapter. So coming to the introduction, meningitis is defined as the inflammation of the meninges that I told already, the inflammation of the leptomeninges or the arachnoid or pia mater, which is surrounding the brain and the spinal cord and also involves the subarachnoid spaces. The infections, the meningitis, is mainly caused by bacteria, viruses, fungi, or the parasite, and among them, the global burden or the morbidity and mortality is more seen with bacterial meningitis. So, we will study in detail what are the causative agents of the bacterial meningitis. Acute bacterial meningitis is a low onset or low duration meningitis. Acute bacterial meningitis is also called as pyogenic meningitis because there is a lot of pus production is there. It is an acute purulent infection within the subarachnoid space. As the name indicates, it is acute bacterial. We can see a high level of polymorphonuclear leukocytes in the CSF. That is an indication that it is a cause of bacterial meningitis. Next one, we should know about agents implicated in pyogenic meningitis vary according to the age. That means the causative agents can vary according to the age of the patient. But overall, Streptococcus pneumoniae is a common. Other agents include Streptococcus agalactiae, meningococci, Listeria monocytogenes, as well as Haemophilus influenzae. Coming to the neonates, that is less than 1 month of age, it is mainly produced by Streptococcus agalactiae, which is the commensal present in the mother's birth canal, and gram-negative bacilli Escherichia coli or Klebsiella, which are present as the commensals in the GIT. So there will be cross-contamination while delivery of the baby can cause infections in neonates. Along with that, we can see Listeria monocytogenes is also play an important role in producing acute bacterial meningitis in neonates. In the age group of more than 60 years, we can see Streptococcus agalactiae again and Listeria monocytogenes, which is the predominant organism which is producing acute bacterial meningitis. Coming to the pathogenesis, how these infections spread in the individuals, and how this, what are the different steps involved in the pathogenesis of these infections. So it is mainly by the bacteria, which is transmitting mainly by from person to person by inhalation of the respiratory droplets of respiratory secretions from nasopharyngeal carriers. Close and prolonged contact like kissing, sneezing, or coughing means someone with an infected person facilitates the spread of infection. And what are the different routes of infection? So how it reaches the meninges from the respiratory tract? It is either maybe because of the hematogenous spread through blood, direct spread from an infected site, and third one is anatomical defect in the central nervous system. And what are the predisposing factors? Predisposing factors include age, vaccination, as well as factors that promote infection at the primary site. So coming to the age, neonates are mainly infected by the meningitis, that is acute bacterial meningitis. Vaccination, the widespread vaccination is shown to reduce the incidence of meningitis. Factors that promote infection at primary site include, because of the respiratory tract is primary portal of entry for many etiological agents of meningitis. So most of the time the infection comes from the respiratory tract. Other factors like through hematogenous spread or anatomical defect also will induce this particular infection. And coming to predisposing factor again, that is continued, presence of CSF shunts. In case of more production of CSF, usually to facilitate or to reduce the intracranial pressure effects, the shunt will be put from meninges, from either from the brain or from the brain to the peritoneal cavity. That is also facilitate this particular infections. Usually there will be contamination and infection of the CSF shunts that can lead to meningitis, and breach in the blood-brain barrier that also will predispose to the condition. What are the different clinical manifestations you are going to observe during this meningeal involvement or meningitis? The average incubation period of this particular infection ranges from 2 to 10 days, and usually it is 4 days. Patient suffers from fever, vomiting, intense headache, altered consciousness, and occasionally they may show the photophobia also. What are the different signs you can see in meningism or the meningeal irritation? Nuchal rigidity, that is the stiff neck. Person may be not able to move the neck properly because of the spasm, and that is referred as stiff neck. Kernick sign is positive. Brudzinski sign is also sometimes shows positive in meningeal involvement. You can see the diagram here. This is the Kernick sign. Patient may not be able to proper the movement. You can see here that we will study later in the other chapters. Involuntary hip and knee fluctuation is not possible, or involuntary movement may be occurring because of the meningeal involvement. And coming to the laboratory diagnosis, we will study in detail. So what are the specimens to be collected and how it has to be transferred to the laboratory? So since the meninges are involved, the associated cerebrospinal fluid also will show the presence of the bacteria as well as inflammatory cells. So CSF cerebrospinal fluid is the most ideal specimen collected for pyogenic meningitis. So in the earlier days, blood culture can be done, which is also another useful specimen for culture. How to collect the CSF from the patient? It is mainly by lumbar puncture under strict aseptic conditions, and it is divided into 3 sterile containers. So we have to send the sample simultaneously for pathology laboratory for the cell count, and we should do the biochemical analysis of that one, because in different etiological agents, the biochemical picture of the CSF will alter or change. And third sample is the microbiology department for the bacteriological examination. So how to transport the CSF? It should be examined immediately. So you should give priority to the specimen, because it is an important and it should not be delayed in processing. Immediately you have to process it. When the bacteriological examination is required, CSF should not be refrigerated, because some of the causative agents are heat sensitive organisms. So in the refrigeration temperature, they may die. So you should not refrigerate. If there is any delay suspected, you can keep the sample at 37 degrees centigrade. This is a change from other systems. Usually, the specimens are preserved at a refrigeration temperature, but the CSF never should be refrigerated. But if you are doing any molecular diagnostic where the live bacteria are not required, at that time you can keep in the freezer also. And coming to the cytological and biochemical assays, so what you can see in the different type of meningitis. So I am discussing now about the bacterial meningitis. This is also called as pyogenic meningitis. You can see the pyogenic meningitis here, the different characters. And in tubercular meningitis, so that is a type of chronic meningitis where Mycobacterium tuberculosis is the causative agent, and different viral agents are also producing the similar conditions. So what are the changes you can see in the CSF parameters when comparing the patient and normal individual? First, coming to the CSF pressure, it is millimeter of water, it is measured. It is normal in normal individual, it is 50 to 150 is the CSF pressure what you can see. But in case of it is highly elevated, that is more than 180. In tuberculosis meningitis, it is moderately elevated. Viral meningitis is slightly elevated, or sometimes it may show the normal CSF pressure. What about the total leukocyte or total WBC count? So it is 0 to 5 per millimeter cube in case of normal individuals, but you can see 100 to 10,000 in case of pyogenic meningitis. But in tubercular meningitis and in viral meningitis, it is almost between 10 to 500 or 25 to 500. What are the predominant cell types you can see in the normal individual? They are the lymphocytes. But in case of pyogenic meningitis, you can see neutrophils are highly elevated because it's acute condition. But in tuberculosis as well as viral meningitis, lymphocytes are the predominant agent because chronic infection is the condition. What about the glucose milligram percentage? That is 40 to 70 is the normal individual. Less than 40 milligram per deciliter. Decrease to absent, you can see in case of pyogenic meningitis. 20 to 40 in case of tubercular meningitis, but it will be normal in case of viral meningitis. So here the reason what you can tell is most of the bacteria utilize glucose as the material for their multiplication. So here the consumption of the glucose by the bacteria may be the reason for the decreased presence of glucose here. But in virus, they are not using glucose as such. But in chronic meningitis by tubercular this one also it won't use that easily this glucose. So that value is almost like a normal individual. But coming to proteins, it is milligram percentage we are calculating. Normal individual, we can see 15 to 45 is the normal value, but more than 45 milligram per deciliter or up to more than 250 you can see in case of pyogenic meningitis, but in tubercular meningitis it is 100 to 500 milligram, moderate to markedly increased, and 20 to 80 you can see in case of The viral meningitis. Again, the same reason here, increase the number of neutrophils, that is large number of neutrophils, what you can see here, 100 to 10,000 will lead to an increased total protein level in case of pyogenic meningitis. Coming to the CSF microscopy or gram staining, if you are doing with the different samples, we have to uh, have some assumption about the bacteria or other agents. So, how we are going to find out the presence of some bacteria in the CSF? CSF is usually sterile and does not contain any of the organisms. It does not contain any commensal organism. So the presence of the bacteria in the CSF is a clear indicative of the infection. So what you are going to observe here, if you are observing gram-positive copy in pairs which are castellated or flame-shaped or lancet-shaped, or gram-positive diplococci which are flame-shaped again with a clear halo that is capsule is there, we can think of Streptococcus pneumoniae. But if the bacteria is again a diplococci which are gram-negative in nature with adjacent sides flattened, lens or half-moon shape, you can suspect Neisseria meningitis. Pleomorphic gram-negative bacilli or coccobacilli which are capsulated, you can see that may be the Haemophilus influenzae. Gram-negative bacteria or bacilli which are arranged singly, maybe Escherichia coli or Klebsiella. Gram-positive copy in short chains may be Streptococcus agalactiae. Gram-positive short bacilli may be Listeria monocytogenes. These are all the different bacteria I told already causing the meningitis, and in CSF findings from CSF microscopy, we have to think about these bacteria. Apart from this one, we can do the direct antigen detection of this one because microscopy may give confusing results if there is a gram-negative bacteria is there. So you can do sometimes the direct antigen detection. It is by taking the supernatant of the CSF. So we have to centrifuge the CSF, then take the supernatant, and the supernatant is used for antigen detection or lattice agglutination test, which are nothing but performed using latex beads coated with anti-capillary antibodies. So, if the patient sample has got the antigens, the corresponding latex beads coated antibodies will give you the clumping, and you can give positive reaction in latex agglutination test. In case of CSF, sometimes there are some studies where urine is also used as a sample. In case of pneumococcal meningitis, some immunochromatographic test, that is ICT, is also available, which detects the C polysaccharide antigen of Streptococcus pneumoniae in urine. So that through blood there will be shedding of this particular bacterial protein, and that can be detected in case of the uh, infection with meningitis. So what you will do for the culture? So depending upon the gram chain reaction, what you are obtaining, you have to do the culture of the bacteria in different media. Ideal media which are used are enriched media like chocolate agar and blood agar. And if you are suspecting gram-negative bacteria, you can use the macroalgae agar. Why? Sometimes you may require the enriching of the substance because even low loads of bacteria in the CSF may not give a direct culture positive. So we have to do the blood culture bottle bedside preferred, or brain heart infusion in the laboratory is preferred for the enriching of the bacteria before the culture. Blood culture can be collected in conventional blood culture bottles, that is brain heart infusion, broth or agar, preferably in automated blood culture like bacteria or alert we can do. Culture plates are usually blood agar and chocolate agar after inoculations are incubated at 37 degrees centigrade, preferably in candle jar, provide 5% carbon dioxide for 48 hours because most of the organisms like pneumococci, Neisseria, they are all sapinophilic organisms. So the presence of 5% carbon dioxide will enhance their growth. So coming to the different culture media and how we can differentiate them in the laboratory. If you are suspecting Streptococcus pneumonia, it produces alpha hemolytic colonies on blood agar. It is also called as Georgeman colony or Taram coil appearance colony on the blood agar. So mainly we can demonstrate the partial alpha hemolytic colonies on blood agar or chocolate agar. So biochemical reaction which differentiate between other streptococci are it is biosoluble, ferment inulin and sensitive to approach. In the case of Neisseria meningitis, it produces non-hemolytic colonies on blood agar, which on smear shows gram-negative diplococci. Biochemical reaction include they are catalase and oxidase positive. They ferment glucose and maltose, but not sucrose. Zero grouping also can be done to identify the zero group of meningococci by using appropriate antivirals. If again continuing here, if you are suspecting again Haemophilus influenza bacteria in the CSF, culture you can do on blood agar with the Staphylococcus aureus streak lines, which is called as satellitism. Biochemical identification by using the X and B factor because they are require this X and B factor from the blood for the proper growth, and you can use the disk of this X and B factor to show the enhanced growth of this organism on the blood agar. Again, coming to Streptococcus agalactiae, if you are suspecting a Streptococcus agalactiae in the CSF sample, it produces beta hemolytic colonies on blood agar, which is shows gram-positive copy in short chains, as I told earlier. In the biochemical reaction, we can do camp test positive and resistant to bacillus, which is favoring towards Streptococcus agalactiae. Zero group of this particular bacteria can be done. It is a group B streptococci in the Langsfield grouping. If you are suspecting gram-negative bacilli meningitis, Escherichia coli and Klebsiella produces lactose fermenting colonies on macroalgae agar. It is identified different biochemical reaction like indole citrate, urease and TSA reaction, that is ICUT test. Non-fermenters, if you are suspecting, in most of the time, where CSF shunts, you can get the Pseudomonas as this particular bacteria, which is oxidase positive, and similar non-fermenter, that is Acinetobacter oxidase negative. Both of them may produce non-lactose fermenting colonies, and the Pseudomonas especially produces pigment on the nutrient agar mediums. If you are suspecting Neisseria monocytogenes, the colony after the colony is formed, we can do a motility test, which is showing tumbling type of motility at 25 degrees centigrade and remaining non-motile at 37 degrees centigrade, called as differential motility. It is due to the temperature dependent flagella expression. So at that is 25 degree, they show the presence of the flagella, but at 37 degree, they does not show the presence of the flagella. Culture, it grows on blood agar, again beta hemolytic colonies, and on chocolate agar as well, it will grow. Selective media like pulp AM agar containing mixture of antibiotics may be useful for isolation of the listeria from the food and environmental sample. Once the bacteria is identified, we have to go for the antimicrobial susceptibility test for the proper treatment. We should done to initiate the definitive antimicrobial therapy. CSF and blood culture take more than 40 hours of identification facility. So prior antimicrobial therapy or of the infection may delay processing. So most of the time, rapid diagnostic tests like antigen detection or molecular tests considered to determine the bacterial etiology of meningitis. So what they're telling here is sensitivity. If you are doing, it may take more than 40 hours and delay in the 40, as well as the sensitivity may alter, or you may get a non-proper reports, or the reports reports you may get if the person has undergone therapy, or if the cultures are not processed properly. In the serological test also some serological test also can be done. That is to detect the antibodies to the antigens of meningococci detected in patient serum by ELISA. It is also useful to do the seroprevalence and know the response of vaccination, and usually it is not done for diagnosis of the infection. Apart from this one, modern molecular techniques also available, which is highly sensitive to detect even few bacteria whether dead or alive in the CSF with less than turnaround time than culture, because I told already culture may take more than 48 hours for and also helping serogroup identification. Multiplex PCR and multiplex real-time PCR also used for the qualitative as well as quantitative organism detection. Biofire film array is another technique which is employed for the molecular method. Common genes which are targeted in the PCR test include for meningococcus we are targeting CTRA, capsule transport gene, and SOLC, CUZ10 superoxide dismutase gene which are specific to meningococci. When coming to pneumococcal, it is LIT-A autolysing gene, PLY that is pneumolysine, and PSA-A pneumococcus surface antigen A are detected. For hemophilus influenzae, conserved capsular gene that is BEX-A is detected. What are the different treatment plans available for phagocytic meningitis? The mortality of phagocytic meningitis is very fatal. That is more than 20% for pneumococci, and among the survivors, up to 50% develop complications. Treatment should be initiated as early as possible before the patient develops the complications. The choice of the antimicrobial agent should be planned based upon the type of organisms and suspected and good CSF penetration ability of the agent. Empirical therapy consists of intravenous inhalers, intravenous taxing or subreactant and vancomycin. If listeria is suspected, intravenous ampicillin added to the regimen. For neonates, intravenous ampicillin plus gentamicin is preferred. Intravenous dexamethasone added to the regimen to reduce intracranial pressure or to reduce the immunological activities. Treatment of diabetes methods again for alternative therapy after culture report is available. Empirical therapy has to be modified based upon the organism. So we cannot wait for the culture report to obtain before giving before starting the treatment. So empirical therapy has to be started once the Lamsini report is available, and the therapy can be modified once the culture and sensory report is properly obtained. And what are the different agents of phagocytic meningitis? So that you should know. Streptococcus pneumoniae, okay. Continuing with the pneumococcal meningitis, Streptococcus pneumoniae or pneumococcus. It is the most common agents of pneumonia. Already told, it is present as a commensals in the uh, nasopharynx, which can directly spread from the in case of some infections like otitis media or pneumonia, either from bloodstream to distant site. or from either by bacteremia, it can enter into the meninges. In the pneumococcal bacteria or the Streptococcus pneumoniae, capsular polysaccharide, C carbohydrate antigen, pneumolysine, and autolysins are the virulence factors. What are the different risk factors associated with the underlying pneumococcal pneumonia that include otitis media, alcoholism, diabetes, splenectomy, complement deficiency, hypogammaglobulinemia, and head trauma. Coming to the second important organism is the meningococcal meningitis caused by Neisseria meningitidis or meningococcus. They are nothing but the castrated gram-negative diplococci with adjacent sides flattened. It is also known as head lens-shaped or half-moon shape. Neisseria gonorrhea causes gonorrhea. Other species are commensals of genital tract or oral cavity, that is the Neisseria lactemica, Neisseria flavacin, Neisseria mucosa, Neisseria sicca, and Neisseria subflava, etc., although they can be occasionally pathogenic to human beings. Next, we will go to the difference between pneumococci, difference between meningococci and gonococci. It is already, I will discuss more about the Neisseria meningitis, which is a causative agent of the acute bacterial meningitis, which is capsulated. Gram-negative diplococci is in lens-shaped or half-moon shape, but in case of Neisseria gonorrhea, it is kidney-shaped. Neisseria meningitis ferments glucose and maltose, but Neisseria gonorrhea ferments only glucose. Neisseria meningitis rarely have plasmids, but Neisseria gonorrhea is having high plasmids number, and Neisseria meningitis is seen mainly in intra and extracellular forms, but Neisseria gonorrhea is seen only in the intracellular forms. Habitat is nasopharynx in case of Neisseria meningitis, but it is in the case of Neisseria gonorrhea, it is genital tract, urethra, or cervix, but rarely not seen in the pharynx. Coming to the virulence factors of the Neisseria meningitis, 13 serogroups starting from, in that mainly A, B, C, X, Y, and W135 account for majority of cases. So invasive disease, non-capsular meningococci and capsular serogroups commonly colonize the nasopharynx and asymptomatic carriers. The different virulence factors of meningococci include outer membrane protein, lipopolysaccharide and endotoxin, immunoglobulin A protease, transferrin binding proteins, and adhesins. Coming to patterns of disease, sporadic infections to endemic disease infections, hyperendemic and explosive epidemics can be produced by the meningococci. Sub-Saharan belt of Africa is the high prevalent area of this particular bacteria. Group A is the leading cause of epidemic meningitis worldwide. Group B and C are major serogroups causing invasive disease worldwide. Group W causes outbreaks in massive gatherings. In India, sporadic cases occurring every year, mainly from North India with occasional outbreaks. Seasonality common in winter and springs. Age 2 peaks 3 months to 5 years or 15 to 25 years. Risk factors that promote colonization include overcrowding, semi-closed communities, schools, military and refugee camps, travelers, especially in Hajj pilgrims. Smoking is also a risk factor. Deficiency of terminal complement components like C5 or C9. Eculizumab therapy, terminal complement inhibitor, hypogammaglobulinemia and hyposplenism also lead to for this particular infection. So, what is the pathogenesis of this particular meningococci? It is again by droplet inhalation. Porter of entry is nasopharynx. Most common, the children are the carriers of this bacteria in their nasopharynx. Nasopharynx to meninges, how they are transmitted? It is mainly by hematogenous spread or direct spread along with olfactory nerve through cibriform plate is possible. Sometimes it can pass through the conjunctiva also. Coming to the clinical manifestations of meningococcal meningitis, apart from the other manifestation what I told already, rashes can be seen. A non-blanching rash, petechial or purpuric rash can be seen in more than 85% of the people suffering with meningococcal meningitis. Septicemia is also associated. Endotoxin-induced endothelial injury can be seen. Increased vascular permeability as well as intravascular thrombosis can be seen. Other condition what you can see is the Waterhouse Friderichsen syndrome in pulmonary meningococcemia, large purpuric rashes, shock, disseminated intravascular coagulations, bilateral adrenal hemorrhage, and multi-organ failure can be seen. So, pyogenic meningitis, you can see 3 to 5 years of age with fever, vomiting, headache, and neck rigidity. Chronic meningococcemia is rare. Repeated episodes of petechial rash, fever, arthritis, and splenomegaly. Post-meningococcal reactive disease, that is, immune complex develop 4 to 10 days after the infection. Arthritis associated with arthritis, rash, iritis, pericarditis, serositis, and fever. Treatment of meningococcal meningitis can be done with the third generation cephalosporin. Penicillin also can be given, however, reduced sensitivity reported from few countries. Symptomatic treatment, aggressive fluid resuscitation for shock and measures to decrease intracranial pressure. Coming to the chemoprophylaxis of that indicated in the close contacts of primary cases. Household contacts and other who are directly exposed to patient's oral secretions in the 7 days before symptom onset. Ceftriaxone single dose intramuscular can be given. Alternatively, rifampicin or ciprofloxacin can be given. So pneumococcal meningitis can be prevented by vaccinations. Polysaccharide vaccine like bivalent A and C or quadrivalent ACY W130 strains used vaccine is employed. 2 doses of vaccine in children of 3 to 18 months, single dose to more than 2 years of children are given. Efficacy is more than 95% and it will protect the children for 3 to 5 years. Indication of vaccination is recommended for high-risk people like contacts of patient during outbreaks, person who is having splenic dysfunction, person who is suffering with having terminal complement component deficiency, person who is taking eculizumab therapy, laboratory staff at risk, international travelers, those who are traveling between the countries. Capsular vaccine is not available for serogroup B as capsule of serogroup B made up of sialic acid is less immunogenic, encephalotogenic due to the expression of similar closely active antigens or on neural cells, not given below 3 years of age in this particular serogroup. Next one is conjugated vaccine, which is given to young children. Addition of a protein carrier adjuvant increases the immunogenicity. So by adding an adjuvant, the immunogenicity of this capsular vaccine can be enhanced. Vaccine for group B, I told already, it is less immunogenic, and a men B vaccine is employed in this particular case. Vaccine contains 4 recombinant protein like adenosine A, heparin binding antigen, factor H binding protein, and outer membrane vesicles OME that is employed here. 2 doses given intramuscular route 1 month apart, and indications is for persons between 16 to 25 years age group. So today I will stop with this particular discussion, and in the next chapter we will continue with the other agents of acute bacterial infections. So in the nutshell, I am going to tell you acute bacterial meningitis was today's topic. We discussed about the different causative agents and in general, what are the clinical manifestations we are going to observe. What are the points you have to remember while doing the laboratory diagnosis? And we discussed about two important bacterial agents, that is the Streptococcus pneumoniae as well as the Neisseria meningitis. Coming to the other organism, we will discuss in the next chapter. Thank you for the patient listening and wish you all the best.